Okay, Assalamualaikum and a very good day to all of our students. This is a briefing for our next practical regarding the cardiovascular system. Okay, so when we discuss about cardiovascular system, most of the disease are related to some form of vascular narrowing causing myocardial ischemia. So these broad disease are termed as coronary artery disease. So, in about 90% of cases, myocardial ischemia results from reduced blood flow due to obstructive atherosclerotic lesion within the coronary arteries. So, what is atherosclerosis? So, when we study the words, actually it's derived from Greek words. Sclerosis means hardening, athero means large artery. So, in textbook term, it is a chronic inflammatory process of arterial wall induced by excessive production and tissue deposition of endogenous cholesterol and other lipids affecting the large vessel. Example, when it affects coronary arteries, it is termed as coronary artery diseases. If it affects our cerebral artery, which the artery supplies the brain, it is termed usually as stroke or cerebrovascular accident. When it affects our vessel supplying our upper limb and lower limb, it is termed as peripheral vascular disease. So the narrowing of the vessel basically occur within the intimal area. So these intimal lesions are called atheroma. Atheroma is actually also known as atheromatous or atherosclerotic plaque. So this plaque actually protruding into the vessel lumen, causing the narrowing. So atheromatous plaque typically consists of raised lesion with a soft coagulated blood with core of lipid, mainly cholesterol and cholesterol ester. So this cholesterol ester later on will be covered by fibrous cap. Okay, so when we want to discuss coronary artery disease, we need to know the vascular supply of the heart because if there is narrowing of that particular area, it will affect the region, the myocardium which it supplies. So when we look at the heart coronary artery supply, usually it start off with the two branch left main coronary artery and also right coronary artery. So this left coronary artery, left main coronary artery, it supplies all the whole left side of the heart, and initially it located at superior end of uh, interventricular groove. Then it branches into uh, left anterior descending and then left circumflex. So these are the left main coronary artery branches to left anterior descending, and then later on it branches into left circumflex. So this left anterior descending, so these are the left anterior descending, it supplies basically the apex of the heart, anterior wall of this left ventricle, and anterior two-thirds of the ventricular septum. Then you have this left circumflex artery. So this left circumflex artery, as you can see here, it supplies the lateral wall of the left ventricle. And it also supplies the posterior third of this ventricular septum. So it is about 20% of individual, small proportion. So when it supplies this posterior third of this ventricular septum, these are the ventricular septum, when it supplies that area, we term it as left dominant. And this left circumflex artery also supplies this, also branch in about 40% of individual, it branch into the sinoatrial nodal branch, which supplies this left atrium and also sinoatrial node. And then you have this right coronary arteries where it supplies entire right ventricular free wall and posterior basal wall of this left ventricle. And in most individual, it supplies the posterior third of this ventricular septum. So if it supplies this posterior third of ventricular septum, like in this picture where it supplies the posterior third of ventricular septum, it termed as right dominant, which usually occur in about 80% of individuals. So this, if there is narrowing of each part of this, for example, if there is a narrowing of the left anterior descending, the apex of the heart and anterior wall of left ventricle will be affected with the myocardial ischemia, and if it getting worse, it will cause the myocardial infarction in this area. And vice versa, if affect left circumflex or right coronary artery, it affect also the area it supplies. And also, if it affect left main coronary artery, the whole area of this left ventricle will be affected. And basically, the whole area of left side of the heart will be affected. Okay, if it's affect the left main coronary arteries. So how does this atherosclerotic plaque occurs? It's actually basically it's from the atherosclerosis. So it start off with chronic endothelial injury. If you remember your Burkhouse triad, you have this endothelial injury. This endothelial injury caused by hyperlipidemia, hypertension, smoking, homocysteine, toxin, viruses, and sometimes autoimmune diseases. So when there is injury, the response will be there is endothelial dysfunction where you have initially leukocyte adhesion, and then after that monocyte adhesion and immigration, and then after that there will be some healing process where there is a macrophage activation, and then you have smooth muscle recruitment, and also there will be some form of smooth muscle proliferation here, as you can see here. And then as it grow worsening, it will cause further narrowing, and usually you can see if you do autopsy, you can see the fatty streak within the lumens, and the lumen is narrowed, and you can see also if you take a biopsy of that area, you can see there is some lipid-laden macrophages and some T lymphocytes. And then after that, it become worsening and worsening and worsening. The narrowing become worse, and you have this fibrofatty atheroma. Within the outside of this area, you have this fibrous cap, and then within that area, you have core lipid debris, you have collagen, you have T lymphocytes. So these are how it looks like lah. As it progress. Later on, I will explain in the slides. Okay, so if you look further forward, close look, you can see again there is a this is the intimal lesion, okay, where you have this fibrous cap on top of it. This fibrous cap consists of this smooth muscle, macrophage, form cell, lymphocytes, collagen, elastin, proteoglycans, and some form of neovascularization. And then you have necrotic center. Within this necrotic center, you can see cholesterol cleft, or also known as cholesterol crystal, form cell, and calcium. Then usually media is unaffected. So these are how the basic structure of atherosclerotic plaque. Okay, so before you understand the pathology, we just need to understand how our heart looks like under the microscope. So in a normal heart, you can see this is how it looks like. Usually they have some yellow tan color like that, where you have this area is uh, this is the left ventricle, right ventricle. This is the septum. So you can see this is parietal pericardium. Then you can see this area is parietal pericardium. This is visceral pericardium, and then within this is the myocardium. This area is the myocardium, and then you can see these are the left ventricle, right ventricle. So this is how it looks like. When we look further under the microscope, you can see these are the cardiomyocytes. So there is a striation, and usually you have this centrally placed nucleus. It is centrally placed, and usually the nucleus is usually is normochromic lah. It's not pycnotic, and usually there is no waviness, and there is the spacing is not so visible. This is the normal cardiomyocytes. For infant myocardium, this is how it looks like. Usually, it's a bit close together. Uh, so usually you can see here it's a bit close together. Then, if the patient have hypertension, you can see there is usually affecting the left ventricle, which is termed as left ventricular hypertrophy. So when there is left ventricular hypertrophy, you can see there is a binucleation of the nucleus, and usually the the myocytes usually this length it's a bit lengthy. You can see like this, it's a bit lengthy, where you have one nucleus and very long, then another nucleus. So it's a very lengthy, and sometimes you can see nuclear darkening. It's some form of pycnotic changes lah, and also enlargement because of the hypertrophy lah. So if the patient have some form of ischemia, so usually we have to know how it looks like under naked eye lah. So usually if the patient have myocardial infarction, within the first 4 hours, usually you cannot see any finding. So after 4 hours, you can see some form of usually mottling, and then, but in this picture, per se, you can see here these are fibrosis, which indicates all infarct. That here you can see this is actually the myocardium that is immersed with the TTC solution. TTC solution is actually triphenyl tetrazolium chloride. This solution actually help us to detect early infarct. So if there is area of necrosis, like in this arrow, there is a staining defect. You can see it's usually, if it is intact, it will be like this red area like this. But if there is an infarct, you can see there is a staining defect, yellowish area like this. So these are the early infarct. And then you can see also this is the cardiac rupture. This is area of hemorrhage, and it's continuously from the left ventricle up until the lateral side of left ventricle. So this is the combination of acute myocardial infarction together with the myocardial rupture at the left ventricular lateral part of left ventricle, and also you can see all infarct here at the anterior part of the left ventricle. So this is how it looks like through our naked eye. So how about we take the biopsy, how it looks like? So usually, as I mentioned earlier, usually within the first 4 hours, it's very difficult to see, where you need an electron microscope to see, and it's not easily available in Malaysia. I think only UM and UKM have that facility for now. So if you see 1-day-old infarct, you can see here there is a waviness of the fiber. It's elongated and narrow. So you can see these are the area which are affected area. These are the normal area. So you can see the waviness are increased, and there is increased spaces in between the myocardium. And then after that, after there is infarct, coagulative necrosis, usually the nucleus will slowly disintegrate, where you cannot see the nucleus anymore. Then there will be a lot of neutrophils coming in. So this is the the uh, myocardial infarction, usually about 3 to 4 days old. And then after that, you the uh, after this neutrophil infiltrate, then there will be some form of removal of the dead cell, etc., phagocytosis, and then after that there will be emergence of these macrophages. So these macrophages, what it do, actually it phagocytize all this uh, necrotic area, and then after that it will slowly uh, um, provide a healing area later on, which later on will transform into granulation tissue. So granulation tissue is a tissue, early early tissue form when there is injury. So these are how granulation tissue looks like. So there is a lot of small vessel with also connective tissue proliferation in between. And then afterwards, there will be heal myocardial infarction where you have a lot of fibrosis. So usually fibrosis, it is usually there is uh, it's not easily seen lah. So in this area, we need Mason trichome stain where it's stained blue lah for fibrosis. So this is a heal myocardial infarction with Mason trichome stain. So usually this is how it looks like. So this is all infarct. So early infarct, the first day, 24 hours, then 3 to 4 days old where you have all these neutrophils, and also there is some form of reaction due to this coagulative necrosis. Then after that, macrophage come out to phagocytize all the dead cells, and then formation of granulation tissue. Then all later on, it will develop this fibrosis. So what if the patient partially treated? You sometimes when the patient partially treated, but there is a gap. That if let's say the patient presented late to the hospital, more than 4 hours, where you have reperfusion injury. So how reperfusion injury looks like? This is how it looks like, where you have this uh, contraction band necrosis, where there is a band, it's thick pink band with necrotic changes lah. So you can see there is no more nucleus, the waviness, and a very thick band formation. So this is all the this is neutrophil, and also some macrophages, but most of it are neutrophil here, neutrophil, lymphocytes. Very few macrophages, maybe this one macrophages. So this is how contraction band necrosis looks like lah. So you can see it's a thick band of the cardiomyocytes, and you don't see nucleus within the cardiomyocytes. So this is the summary of what I said earlier. So just try to remember at least the 4 pictures I described earlier on, and also try to remember this contraction band necrosis. This is also a favorite question we like to ask lah. Okay, so we move on to the practical, the actual slide to coronary artery. So when you look at the slide later on, this is how it looks like. So first you see this is the pathology. There's a narrowing of the coronary artery. You can see very much narrowing. It is, and then you can see surrounding the coronary artery there is a very thick fatty layer. This is all adipocytes. So if patient have myocardial or coronary artery pathology, usually the patient will have some risk factor, commonly increased obesity, and also this obesity will leads to increase in visceral fat. So this is how visceral fat covering the coronary arteries looks like. Okay, so very thick. Then you can see the remnants of the uh, myocardium, which have some form of necrotic changes. See, you cannot see the nucleus anymore. So you see also there are some spaces in between. Then we go to higher magnification. You see again, there is no more nucleus adjacent to the cardiomyocytes. So cardiomyocyte, no more nucleus, and there is increased spaces in between. So again, you see increased spaces in between, thick uh, fatty layer. So this is usually increased visceral fat lah. Usually when you biopsy the usually the coronary artery and also some part of the myocardium lah, adjacent to the pathology. So this is how uh, the necrosis, coagulative necrosis looks like lah. But these slides, forgive us, these slides a bit faded, so you cannot see much of the WBC changes. And then we go back to our main pathology, coronary artery. Again, you see there is a narrowing of the coronary artery. You see it is severely narrowed, or we also term as critical narrowing of coronary arteries. And then here you can see the center, you can see this cholesterol center, necrotic area. And then this is the cholesterol cleft. You see this lining, white lining here, spaces, white spaces. This is the cholesterol cleft. And this is this area, dark, light red. This is the part of the thrombus lah. And then you see this is the fibrous cap, which is overlying the coronary artery. So this is how it looks like under the microscope lah. The coronary artery which has a critical narrowing. So try to understand the pathology, try to describe. Of course, it start off with intimal lesion, which is the atheromatous, or you can call atheroma or atheromatous plaque or atherosclerotic plaque. So this plaque have this center, necrotic center, which have this cholesterol cleft. This is the foam cell. This spaces, circle spaces. This is a foam cell, and then you have this dark red and light red. This is the plaque, thrombus plaque, which is also overlying the necrotic center, and then you have this fibrous this fibrous cap. So this is how it looks like. First, narrowing. Second, narrowing, mention it how severe it is. If it is more than 70%, it is critical narrowing. Then you mention the center, which is the necrotic center, which consists of this cholesterol cleft, foam cell. If you see like this, maybe it's difficult because the slide has faded. Sometimes you can see maybe this area, this is the lymphocytes and neutrophil, the WBC. And then you see the light red, the bright red, and also the pale red. These are the area, the thrombus plaque. And then you see it covers by this fibrous cap. So this is the coronary atherosclerosis, which critical narrowing. So this is how you basically the diagnosis will be if the patient died, you can say it is due to a coronary occlusion by atheromatous plaque, or if you say the patient died due to acute myocardial infarction, also I accept the answer lah. Okay, this is our practical, basically just one slide. Try to slowly appreciate the findings and try to also relate back to the knowledge I explained earlier. We will not only asking the pathology finding, we also would like to ask the practical part of it. For example, which of the vessel are commonly affected, and which vessels supply which areas. That's that kind of question. So I think that's all from me. So we will see you guys in the practical. Okay, have a good day, everyone.